Thank you very much. And first, once again, I'd like to join in with the other people who have thanked the Howard Foundation for making this meeting possible. It's been an extraordinary meeting thus far, and I'd also like to reassure you that we will make lunch. The beginning of this is very much revision, and we can speed through that. None of us would be here today if it wasn't for AREDS. AREDS provided us with proof of principle and put wind in the sails of the antioxidant theory of age-related macular degeneration. It was 3,000 participants and 1,000 controls, followed for 5 years. Fascinated to hear what John Paul said, and I agree with what they seem to have done in AREDS too, which is change this. This is important. We have to concentrate for this bit. In AREDS, controls were essentially free from disease. Category 2 had basically very mild AMD, few pigmentary changes, discrete drusen. Category 3 had absence of advanced AMD, but they did indeed have large soft drusen, or the bad drusen, and this was a little bit confusing for me. They also had atrophic changes. They were allowed to have atrophic changes, albeit non-central. In my mind, that's advanced AMD, but that's the way they did it. And category 4 had basically advanced AMD in one eye and AMD in the other eye. So as you go up this way or down the slide, the risk gets greater. What they did was they gave extortionate doses, which would be completely beyond regulations in the European Union, of vitamin C, vitamin E, beta-carotene, lutein, and zinc and copper. And what they found was they collected data every year for a minimum of 5 years, but did check vision every 6 months. And they compared zinc versus placebo, antioxidants versus placebo, antioxidants and zinc versus placebo. And what they found was that indeed there was a 25% risk reduction of morphological progression of AMD in those who got both zinc and antioxidants. Now, they also found a benefit in association with treatment versus placebo in terms of retaining vision. Now, I've mentioned that what this did to everybody in this room was it really lent credibility to this notion of antioxidants being good for AMD. It provided proof of principle. It's very, 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 very difficult to do a good study like AREDS, and it's very, very easy to criticize a study like AREDS, but it does have a few criticisms which warrant mention. The first is beta-carotene. There is no beta-carotene in the neurosensory retina, so the biologically plausible rationale was lacking for using it. And it turned out, they didn't know at the time, that beta-carotene causes cancer in lung cancer in smokers, and we know that smoking is associated with AMD. The other problem was, and again, it was not the AREDS investigators who were to blame here, because L and Z were not available in supplement form in '93, or were barely available. And it would seem obvious now, if antioxidants are good for you, well, the appropriately and anatomically located antioxidants would be very relevant, and especially an antioxidant that not only was an antioxidant, but also filtered blue light and therefore prevented or attenuated the generation of reactive oxygen intermediates. So that's two criticisms. The third one was the doses, which in many countries would never be allowed. I'm going to do what Billy Wooten did yesterday. I'm going to not talk about things I don't know about that much. And Julie summarized the last two tables here very well. And these are mainly cross-sectional studies looking at serum concentrations of lutein and zeaxanthin and dietary intake of lutein and zeaxanthin with respect to risk for AMD, and they're inconsistent results. Of course, they're not the correct design either, so you can't really blame them. There's been about 5 or 6 studies looking at lutein and zeaxanthin supplements in AMD or in normal subject interventional studies. And although the majority do report a benefit, they are short in follow-up and sometimes not even including controlled subjects. So we have to be very, very cautious. And it's also interesting, I think, although AREDS set the sail in motion, AREDS 2, we're all waiting for it with such bated breath that it has stunted anybody else even embarking on a study because it's so massive. But we did do one study, and that's what I'm going to present today. It's known as the KARMA study. And this was set up in 2003. And this is the CARMA team. You recognize Robert, he's here in the audience. And I'm not there, actually. But there's Usha Chakravarti. Usha and myself were the principal investigators. This is Mike Stevenson, the statistician. And there is John Nolan and Etna Connolly. It was supported by Bausch and Lomb, so I'd like to disclose at this stage that myself, Usha and John have been in receipt of honoraria when we speak on their behalf. As I say, principal investigators were myself and Usha. It received Ethics Committee approval in the two centres, both in Waterford and Belfast, and it was registered with the European Clinical Trials Association, and all the materials and methods have been published in the Journal of Ophthalmic and Epidemiology about 2 years ago. So some of the very, very complicated statistical questions, I might be able to answer some of them, but they're all there and already published. It was very simple to investigate the putative beneficial effects of L and Z supplements in age-related macular degeneration. It was randomized, it was placebo-controlled, it was double-masked, it was a parallel group design. So it was not a factor design because we simply knew from the outset that we would not have the follow-up or the number of subjects. There was a minimum follow-up of 12 months, but people who were recruited early on often were followed up for 3 and sometimes a little bit more years. This is the consort diagram. So 216 were randomized to treatment and 217 to placebo. And these are the drop-offs. So at 12 months, we had 171 and 172. Important to bear in mind that obviously there were 2 groups of reasons for dropout. One was attrition or personal reasons. But the other was, obviously, patients recruited 13 months before end of trial were only ever going to have 12 months of follow-up. So the numbers are small as late as 36 months. There were 2 types of eyes that we recruited. The first type was, and this is very consistent with what John Paul was saying, we knew we had limitations here. It wasn't going to be AREDs, we weren't going to be funded for that long, so we wanted high-risk eyes. So group 1 eyes had advanced AMD in one eye and AMD in the other eye. So those eyes, because one eye is already gone and because both eyes share an identical background, are at very high risk of progression and visual deterioration. Obviously, we excluded ocular pathology that may confuse things. Group 2 had at least 20 drusen in the study eye, and they were allowed. And they were soft, but they could be distinct or indistinct. And they were allowed to include both eyes in the study, but don't worry, we did weight it accordingly for the non-independence of paired eyes in all statistical analysis. It was 12 milligrams of lutein, 2 milligrams of zeaxanthin, and very small European doses of vitamin C, E, zinc, and copper. We looked at 3 things: the ocular parameters, which were best corrected visual acuity, contrast sensitivity, fundus photography, and Raman was our measurement of macular pigment. In serum, we looked at lutein, zeaxanthin, but also vitamin C, E, zinc, and copper. And we did a questionnaire with respect to diet. The primary outcome measure, and this was a priori, published before we analysed the data, was best corrected visual acuity at 12 months. The secondary outcome measures were best corrected visual acuity and contrast sensitivity whenever, Raman, serum concentrations of lutein and zeaxanthin, and AMD severity. Some of the statistics obviously got complicated when we were looking at, for example, relationships between serum concentrations of, say, zeaxanthin or vitamin C or lutein. With respect to visual acuity, we used a general linear modelling technique and repeated measures. And when we were looking at stage or progression of AMD, we used an ordinal regression modelling when trying to correlate that to serum concentrations of various parameters. And here are the results. Visual acuity. Visual acuity over time, this is the active treatment group versus placebo. And in case you're wondering why you haven't seen this data up until now, it's because it was only submitted for publication to ophthalmology about 4 days ago. The active treatment group did show over time a visual improvement. The placebo group did not. But what is really important is this graph here. This is a differential change in best corrected visual acuity in study eyes from baseline between the two groups. And this is interesting. No change, no change, no change. And look, at 36 months, albeit small numbers, there was a significant advantage in terms of best corrected visual acuity. And for me, this is intuitive. It's a chronic disease which is the result of cumulative damage. The notion that supplements would change vision before that or result in a visual benefit or a visual advantage before that intuitively would not fit with my way of thinking. Contrast sensitivity, and we're open to criticism here, and I'm sure the vision scientists in the room will all criticize us, but you have to remember that the trial was elderly subjects, so time was of the essence. We couldn't have 6-hour visits. We used the Pelley-Robson chart, and Pelley-Robson chart did show a trend towards an advantage. This is a differential change in contrast sensitivity in study eyes from baseline between the two groups, and there was no statistically significant advantage in terms of contrast sensitivity. We looked at macular pigment, and again, we would be open to criticism here. We used the Raman spectroscopy. This was a very pragmatic decision at the time in 2003. We wanted a click button technique. We did not want a heterochromatic flicker photometry in this population. What we found was very interesting. Macular pigment with Raman did in the active group did increase over time, but it actually decreased significantly over time in the placebo group. And we speculate that the loss of photoreceptors with the passage of time, reflected in the better vision result in the treatment group and not seen in the placebo group, may have been associated with a loss of photoreceptors and therefore housing for the macular pigment. However, this is Raman with all its limitations, which we accept, and even a small progression of cataracts in the cataract subjects will have dirtied this data, and we concede that. We then looked at serum lutein, and surprise, surprise, and very reassuringly, the treatment group did show a massive rise in serum concentrations of lutein, and none seen in the placebo, which again is very reassuring from the perspective of compliance, etc. Now, progression of AMD, 39 subjects in the treatment, 39 subjects in the 33 in the treatment group and 39 in the placebo group went on to get late AMD. However, from the outset, this study was never going to be powered to detect a difference. So although there was an advantage in terms of progression of AMD in association with treatment, it was not statistically significant. At some stages, it did approach statistical significance, like at year 1, for example, it was 49% versus I can't remember the exact figures, but at some stages it did approach it, but it never reached statistical significance, but nor was it powered to do so. So then we looked at the two most important outcome measures, which are best corrected visual acuity and AMD severity, with respect to serum concentrations of lutein, zeaxanthin, vitamin C, vitamin E, and zinc. And the only one that showed a benefit was serum lutein, and this was statistically significant, such that a 1 log unit increase in serum lutein was associated with 1.4 lines of best corrected visual acuity improvement. And with respect to where AMD stage was the dependent variable, we found that a 1 log unit increase in serum lutein, which was only seen in the subjects who were supplemented, was associated with a 0.2 retardation of progression of AMD. And again, this was statistically significant. So in conclusion, this randomized controlled trial, although it failed in its primary outcome measure, which was always very ambitious, best corrected visual acuity at 12 months, did show that, and albeit with small numbers, at 36 months, supplemental lutein and zeaxanthin did confer an advantage in terms of best corrected visual acuity. Also, higher concentrations of lutein and zeaxanthin seen only in the treatment group was associated with a slowing down of progression, morphological progression of AMD and in terms of best corrected visual, and an advantage in terms of best corrected visual acuity. So, despite its limitations, despite its small numbers and short follow-up, we do feel that this randomized controlled trial is suggestive of an advantage of macular pigment supplements in patients with early AMD. Thank you very much.